Sugar daddy. If you're down cause your A1C is high, all you have to do is listen to our guy. Sugar daddy, sugar daddy, sugar daddy, ooh, sugar daddy, sugar daddy, sugar daddy, the man with the diabetes plan. Hey, sugar daddy, sugar daddy, hey, sugar daddy.
Hi everybody, I'm Dr. Frank Lavernia, also known as Sugar Daddy. I'm here with my colleague Carrie O'Day, who is one of our co-hosts, PAs. And how are you doing today? Good?
I'm doing well.
Good,
Thanks.
good. Today we're going to talk about chronic kidney disease. You're going to hear CKD over and over. It's very common. It's a silent complication. Unfortunately, I've been caught having to tell a lot of patients that were not aware, and you'll see why they were not aware, that they have underlying serious kidney disease. It's a microvascular complication, so it's a small vessel complication. And people with diabetes, that's one of the first ones they get hit is small vessel complications. Why does it matter? Well, it can creep up on people and they really don't notice it. You know, they think they're going to have back pain or they're going to have visible changes in the urine. I don't see any blood in my urine, or I make plenty of urine, but they don't understand that it's not the right type of urine. And finally, you know, when you think about it, I like this analogy. It's like a slow leak in your house's plumbing, but by the time you see the problem, it's often well advanced. So if people with diabetes often don't notice chronic kidney disease until it's progressed, how can we catch it a little bit earlier?
Yeah, that's a good question because it is one of the major microvascular complications, but if it's silent, how are we going to know? People aren't going to have symptoms like you referred to, back pain, blood in the urine, decreased urine output. They would expect something like this, but no. This is all about screening, and regular screening is very critical, especially throughout the diagnosis, but also when people are first diagnosed with type 2 diabetes, they need to be screened pretty much immediately. And then people with type 1 diabetes, because we tend to catch that a little earlier in the progress sometimes when people are a little bit younger for multiple reasons, that can be, you can wait a few more years, but at least by 5 years, screening is absolutely essential. So what tests? What are these screening tests that we're running to look for chronic kidney disease?
Yeah, so there's two main tests, and I know at this free clinic that we were volunteering at, that was a problem that a lot of the physicians were not testing.
Yeah.
And it's as simple as getting a urine test and a blood test. Let's talk a little bit first about the blood test. We call it the estimated GFR. And it's an approximation. It can change from day to day, but it's a good test to have. And it's typically based on a creatinine level that's plugged into this formula. And there's other things that you plug into the formula, but the major labs, when you get the results, it's on the results. And I'm always surprised when I have patients that when they tell me I can't find the eGFR. It's there, right around the creatinine and the BUN, the blood urea nitrogen. Go look, it's there. And it's important that they know what it is. Now, there's another test, and there's going to be other tests that are coming in the future, and we call this the cystatin C test. But that's in particular cases. The nephrology people like to use it more. It's a little bit more exact, but many times it's not covered, say, by Medicare. So you're gonna have to pay for some of the tests. So we go with the estimated GFR. It's there, look for it on your results. And the second test is a spot urine. So in an ideal world, you would take it in the morning, first urine. You tell patients don't exercise, don't eat this, don't eat that, and let's get a spot urine. But when everything is said and done, just while they're there, get a spot urine. And basically, what we're measuring is the albumin to creatinine ratio. So you'll see urine ACR, and that's a critical early marker for kidney damage. And as we're gonna talk about it later, how it's a surrogate for cardiac disease.
Yeah.
Because the endothelium, the lining and all these small arteries are throughout our body. So if you're leaking protein from your kidneys, bad things are happening in other parts of your body. So be aware of these tests and pay attention to what the results are. So one of the things that some of the physicians get caught up with is, well, your EGFR is normal, therefore you're okay, but you're not okay. If you're leaking protein out of your kidneys, you've got a serious problem and it should be treated aggressively. So the Kadoki people, and I'm not going to go through the whole acronym of it, they came out with a heat map. And at the clinic, we actually would show the patients this heat map, and they would have green areas, yellow areas, and red areas. And we would ask them, with the patient in front, let's see where your EGFR, and it's broken into 5 stages. And on the graphic, we'd literally put our pen on it, and like, here's where you're at in this area. And then there was another area that measured in 3 different areas how much protein you're losing. So when you graphically pin where these come together, they would look up and it says, I'm in the red zone. And they're totally asymptomatic. And that's what we finally saw, that we were getting their attention. When we would sit there and graphically plot out where they were sitting on this. So okay, let's go on. So what's the importance of catching this early? What's the connection to this heart health problem?
So chronic kidney disease isn't just about the kidneys. It also means if you've got some kidney disease that you might, or you're much more likely to have heart disease. So high albumin in the urine, or albuminuria, and a reduced EGFR are both linked to higher cardiovascular mortality. So this is important for people to know, and this is important to follow, because we also know that if you've got possible heart disease, you're going to need to keep that cholesterol down. So that's how that all comes into the picture. So lowering LDL cholesterol is a critical part of taking care of people, and it's a very critical part of chronic kidney disease management to help reduce this cardiovascular risk. So once we spot chronic kidney disease, what's a plan to treat it?
So it's interesting. In the last few years, we've been talking about pillars, building pillars like the old Roman temples. To hold that temple up, there's pillars. And in congestive heart failure treatment, there's all of these different pillars, and they all have names, medication names. The same thing is happening now with pillars of CKD, pillars of chronic kidney disease. So for instance, one of the drivers, the number 1 driver of chronic kidney disease right now is diabetes. A close second is hypertension. So there's all of these antihypertensive medications, but to protect the kidneys, there are better types of medication. And those are the ones we call the RAS inhibitors. And some of you might be on an ACE inhibitor. Some of you may be on an angiotensin receptor blocker. We'll call them ARBs. Whatever you do, you don't want to be on both.
Right.
Because you run the risk, you could maybe tolerate them, but you run the risk of having high potassium. And that's something we do not want, especially in people with diabetes who have high cardiovascular risk.
Right.
So we're throwing gas on the fire. So be sure you're on one or the other, but be on one. Now, a few years back now, there are a new group of drugs. You see them on TV all the time, the SGLT2 inhibitors, and you might know them as Farxiga, Invokana, Jardiance. There's a few others. And it turns out that these drugs have become very important, not as a diabetic drug, but on a drug to slow down this downhill slide we're having with chronic kidney disease. So it's important you start taking low dose and then later a higher dose and be monitored to them. It's once a day pill, very good pill. The prices are gonna drop in the next few years. They're still kind of pricey, but we're talking about protecting your kidneys so you don't progress to stage 5, which is end-stage renal disease. Finally, we also know that in a different mechanism of action, we have these newer drugs that are anti-inflammatory drugs. And we've been talking about that diabetes is a cardiovascular inflammatory disease, and we try to slow this down with this new product that's called finerenone, also known as Kerendia. That's the brand name. And the only thing you have to be careful with that is the magical high potassium. So if you're running a high potassium, your doctor might tell you, you don't tolerate it, we can't use it. Now, why are all of these different drugs? Because they all have different mechanism of action, and they have this symbiotic relationship, complementary relationship, so we can use them together. But the name of the game is slow down this progression of kidney disease. Finally, last May, actually it's going to be almost a year and a half now, there's semaglutide, what you know as Ozempic, came out with a FLOW trial. And the FLOW, F-L-O-W, showed that not only do you get cardiovascular benefits, but you also get protection for your kidneys. You're also going to lose weight. Why would you not think about using this? So now we're saying, hey, we got these combination of therapies. They're quite expensive, but more expensive is being on dialysis.
Yeah.
What do you think the listeners keep in mind to stay ahead of the CKD? What points would you make for them?
So 4 key points, I think. Number 1, CKD often, chronic kidney disease, often progresses silently. Don't wait for the symptoms to appear. Number 2, regular screening, right?
Yeah.
That will let you know what's going on before symptoms. So you want your EGFR and you want your urine ACR. We need to catch any changes early, and that will allow your provider to help preserve kidney function with some of the medications we discussed. And then what are these medications? Early in treatment with an ACE inhibitor or an ARB, not both, one or the other, very important for blood pressure control, that be the choice, not both. We don't want high potassium. And then an SGLT2 inhibitor, you were talking about the Jardiance, that will help, as well as these non-steroidal MRAs, which the one is finerenone or Kerendia. They can make a big difference. And don't forget about the GLP-1 receptor agonists and also managing your LDL cholesterol, because that cardiovascular health is key to you being healthy longer. So what's on deck for the next episode?
Well, we're going to talk about something, and maybe we should have talked a little bit before, but we already mentioned the importance of knowing what kind of type of diabetes do you have. And people are walking around thinking that there's only 2 or 3 types of, and that's not true, as we're going to find on the next talk that we have. So again, please subscribe to Sugar Daddy Podcast, and remember, you can do this.
If you're down 'cause your A1C is high, all you